Welcome, everyone. I'm Paul Irwin, Dean of the UAB School of Public Health. I'm excited to welcome you today to this career conversation with alum Dr. Kayvon Modjarrad. Today's webinar is made possible by the School of Public Health's Office of Public Health Practice and the Development and Alumni team. Please feel free to check out their respective websites and social media channels if you would like to learn more. Now, without further ado, I'd like to introduce Dr. Kayvon Modjarrad, our speaker, our guest for today's career conversation. Kayvon Modjarrad, MD, PhD, is the founding director of the Emerging Infectious Diseases branch at the Walter Reed Army Institute of Research, an associate professor of medicine at the Uniformed Services University. Dr. Modjarrad, who is the principal inventor and lead for the U.S. Army's vaccine against COVID-19, also leads all of Walter Reed Army Institute's COVID-19 response efforts. Dr. Modjarrad and his team have developed the SARS-CoV-2 nanoparticle vaccine in clinical trials that targets broad protection against multiple coronavirus species. Dr. Modjarrad also serves as an advising member of Operation Warp Speed Countermeasures Acceleration Group and is a U.S. member representative to the World Health Organization's Strategic Advisory Group of Experts Immunization Working Group on COVID-19 vaccines and vaccination. He has also led the U.S. Army's Zika vaccine program and was assigned to the WHO in 2015, where he supported the execution of Ebola vaccine trials and authored the roadmap for MERS coronavirus vaccine development. Dr. Modjarrad, originally from New Jersey, began his training in biology at Duke University and then went on to obtain his MD, MPH, and PhD at UAB through the National Institutes of Health funded combined degree medical scientist training program. In the course of this training, he lived in Lusaka, Zambia from 2003 to 2004 as a Boren Fellow, where he established a research clinic, implemented a study to evaluate the impact of parasitic infections on HIV, and bolstered local infrastructure in preparation for the US President's emergency plan for AIDS relief. He then went on to complete his internship and residency in internal medicine and a fellowship in infectious diseases at Yale, Vanderbilt, and the NIH National Institute of Allergy and Infectious Diseases. He has published more than 90 peer-reviewed manuscripts and served as the principal editor for 2 textbooks, one on vaccinology. Dr. Modjarrad, it is a great honor and pleasure to have you join us today in this career conversation. Welcome back to UAB.
Thank you so much, Dean Irwin. It's a pleasure to be here, and I thank you for the kind introduction and the invitation to speak with you today.
Wonderful, wonderful. So you heard me describe a little bit about your background, a 30,000-foot overview. Tell us a little bit more about yourself and where you work and what your primary responsibilities are.
Sure, I feel like you gave a lot of details, and I don't want to bore people too much with just reciting my resume. I learned a little bit more about my origins actually over the past couple of years. My family immigrated from Iran before I was born in New Jersey, as you mentioned. But apparently there are folks in Iran now with the advent of our vaccine who've different cities have started to claim me, even though, the only one that has the right to claim me is Englewood, New Jersey. But at 17 years old, I headed down south and did most of my training in the southern states with a little brief stint for my intern year at Yale, but then everything else was below the Mason-Dixon line. And then, as you mentioned, I went even further south of the equator to do part of my PhD research in Zambia. So all of that led me to my current position at the Walter Reed Army Institute of Research, as you mentioned, in the Emerging Infectious Diseases branch. And this was a position that was completely new that I was recruited into to build an entirely new unit that never had existed before at the Department of Defense, and really not within any of the intramural institutes within the federal government. Walter Reed Army Institute of Research, which we shortened to calling RAIR, W-R-A-I-R, is the oldest and the largest research institute within the Department of Defense. And its mission is to develop solutions for our active duty members of the military, but also, there are obviously commonalities between soldier populations and civilian populations, and much of what we do is relevant to civilians in the U.S., but populations overseas and advancing the mission of global health. Our motto is soldier health, world health, and how the two are very much integrated. And the Emerging Infectious Diseases branch is very much a recapitulation or reflection of that mission, but just focused towards emerging infectious threats and surveying, anticipating, and developing prevention and therapeutic and diagnostic solutions for these emerging threats.
Great. So technically speaking, you're an employee of the Department of Defense, a civilian employee.
That's right. I am a medical officer civilian in the Department of the Army in the Department of Defense.
Okay. And as such, and as I described in introducing you, that work has really put you on the leading edge of vaccine work for a number of different conditions that would first and foremost pose a risk for Department of Defense employees who would be deployed.
That's right. And that's and we can talk about this, but my passion for vaccine science, vaccinology started at UAB School of Public Health. And so that led me along a sort of a 20-year path to where I am now. And that's what took me to the NIH, to the Vaccine Research Center. That's where I completed my fellowship and transitioned to as an early investigator. And then it is also what attracted me to the World Health Organization for that year there. And then what really drew me to RARE, because RARE has a long legacy of vaccine development. People like luminaries in the field like Albert Sabin, who developed the oral polio vaccine, Maurice Hilleman, who is credited with inventing 23 different vaccines and led Merck's vaccine program for many years. These are the kinds of people that have come through the halls of RARE. And I wanted to be part of that legacy and work with a lot of those folks who were trained by those people that I mentioned. So the whole kind of arc of my career path and where I've been has been unified in retrospect now. It wasn't always apparent to me at the time, but this common thread has been one of working on diseases that have global relevance and developing vaccines primarily for those diseases.
Let's start back at the beginning with you being here at UAB as a student. You chose to go the MD-PhD combined degree route. And ostensibly that decision was made while you were still an undergraduate at Duke, approaching medical school. How did you make that decision and why? Why the combined degrees?
My first passion had always been to be a doctor. You know, there's a joke among Iranians, Persians, that you have two options. You can either be a doctor or an engineer. And I chose doctor. But actually there was no pressure within my family, and there hadn't been a physician in my family as of yet. But something about it, you know, from the time I got my first Fisher-Price doctor's kit when I was 5 years old, really drew me to that profession, first and foremost. And I thought that's the pathway that I'd be going down. But I always had a love of science and a love of scientific discovery. I worked in laboratories in high school, and then continued that as a work study student at Duke. And I thought, well, is there a way that I can do both? I sort of knew that you can be a physician and do science, but I started to explore these pathways. And I had a mentor at Duke who introduced me to, he was a PhD, but he knew about the MD-PhD program. And then I started talking to other folks on campus who had gone through this NIH-funded medical scientist training program. And I think sort of being in the South, I learned when I went to Birmingham that the 4 years that I spent in Durham, North Carolina did not count as the South. But getting a little bit closer into to that region of the country, and then also the fact that UAB had this MSTP, one of only about 30 medical schools in the country to have this funding from the NIH in support of this program, that opened up then my eyes to the MSTP and then to UAB as well. And then there was also the financial aspect. I have to be honest, I thought, well, I can do both of these things, pursue in education in that would lead me towards a career in research, but also a career as a clinician scientist. But with the NIH funded program, it was all paid for. And coming from an immigrant family of modest means, that was actually important to me as well.
Yes. I can understand that, absolutely. You mentioned earlier that you first got interested in vaccinology in your experience here at the School of Public Health. Can you tell us more about that?
Yeah, absolutely. I remember the first class, the first day. It was my second year of coursework, and it was taught by Sten Vermont, who ended up being my PhD advisor and now lifelong friend and mentor. And I think it wasn't just the topic; it was the infectious enthusiasm. The pun not intended, but yeah. That Sten brought to the field, and realizing that as many patients that I could see in a lifetime, working on the development of one vaccine could have an even greater impact in many ways, and saving people's lives and improving the health of populations. And so I just was immediately excited about this field that I didn't really know much about until I matriculated in this class.
And for our audience, just to round this out, Dr. Sten Vermont had been the director of the Sparkman Center for Global Health while he was here at UAB, and then went on to Vanderbilt, and is now the dean of the School of Public Health at Yale, but is also serving on our external advisory committee for the Sparkman Center. So we remain connected to him. So you mentioned the course with Sten. Any other specific courses that come to mind that were particularly beneficial to you on your path?
I mean, I think in medical school in those first couple of years, the exposure to microbiology and immunology obviously influenced me. I had thought that my interest had really been focused towards neuroscience, neurobiology. I thought that's the path that I would be taking. And I didn't have exposure to some of these other areas until I got into medical school. The other thing is that UAB, the MSTP also, I don't know if they still do this, but at the time they required all of the first years to also take the first year cellular and molecular biology graduate series of courses. And there we got exposed as well to microbiology and immunology from a different perspective. So those foundational courses were important. And then foundational courses actually in school public health were really important as well for me. The introduction to epidemiology at that time was taught by Phil Colt. I mean, just an amazing teacher, speaker, but I mean, here's somebody who really was very well known in the field of epidemiology and epidemiologic methods, who could translate to first year school public health students the basic principles. I mean, I was really lucky in the professors that I had in those courses. And then you know, we can, I think there might be some question you might ask about this too, but the field work that I did as part of my research when I was in Zambia, and the clinical rotations that I did in medical school. The coursework was very important, but I think even more important to my education was that practical education out in the field and in the clinic. I think that was invaluable in taking some of those early lessons that I learned in the courses and then applying them into the real world.
Let's get you to talk a little bit more about your work in Zambia. How did that come about? What did you do there, and how did that influence your career after you returned from Zambia?
It was one of the seminal moments in my education and career development, and also in my life. I came back a different person. I had traveled abroad a few times. Actually, the way I got connected with STEM, and in some ways started thinking about coming over to the School of Public Health for my PhD, was through a scholarship program that the medical school had that sent first year medical students between their first and second year to an overseas sites where faculty at UAB had been doing work. And I successfully competed for that scholarship, and then I got connected to STEM, and then STEM was doing work in Mongolia at the time. And I got assigned to go to Mongolia for 2 months to work with a team of Mongolian physicians who were carrying out a WHO survey looking at the coverage of hepatitis B vaccination in the country. And this was a new campaign. A lot of the public health infrastructure had degraded after the fall of the Soviet Union, which was a primary benefactor of Mongolia. So that started that kind of focus on international health, global health, and that connection with STEM. And I had a strong interest in HIV research, and to some extent in parasitology. I had done as part of what would be considered a master's thesis with Susan Allen, and the work that she was another one of the faculty at UAB at the time. It's now at Emory, and she had two major cohorts HIV discordant couple cohorts in Zambia and Rwanda, and worked with her on data from those cohorts there in Birmingham. I worked on those data, but then that also kind of connected me again with Sten, who had been doing a lot of work in Zambia, and it created this non-governmental organization called the Center for Infectious Diseases Research in Zambia, CITERS, which for many years was part of UAB, and I think now it's become an independent organization. It was, some of this is serendipitous, some of it is kind of gravitation towards shared interests. And there was a grant that was being written to look at the impact of parasitic infections on HIV disease progression. I came in right at the time that grant proposal was being written. So I had the great experience as a graduate student to work on a grant proposal that was funded by the NIH, and then to write a study protocol, and then go and implement the study at the site overseas. I mean, from soup to nuts, I had the whole experience from conception all the way through, clinical evaluation, analysis, and interpretation, and write-up. So that holistic experience was really valuable to me. But then also living in Zambia for a year to implement that study, at the age of 25, 26 was. It was really kind of a monumental experience in my life, and the kind of real life education that I got there, it really changed me and changed who I am, but very much for the better.
Yeah, I can certainly resonate with that. I know my global health experiences are what put me on the path that I'm still on in public health. The opportunity to experience a different culture, a different landscape, a different perspective on life and health, I think really does become a life-changing event. I'm going to pick up a question from the audience, if I could. And that question is, your educational and career journey are inspirational. What advice do you have for translating your passions as a student into a career after graduating? Do you have any recommendations for finding opportunities that will lead to such a fruitful career?
It's a great question, and I thank the audience member for that question. I think about how I ended up here, and it's not been a linear path, and my interests have changed over time. They've sort of, in many ways, focused, and it has come as the result of exposure and exploration. One of the things that I tell people is that, who are coming up through their education, that it's okay not to know what you want to do for the rest of your life. I think that is actually the normal, even though we're told that oftentimes that you should know. And what you want to do changes and should change if you are someone who is responsive and adaptive to the experiences around you. And but what I would say is to, I always pause at this moment so that I don't sound like I'm just issuing some platitudes like it's a commencement address. But I would say that it is important to follow your passion. It is important to, if it takes you off the straight and narrow path for a little while, that's probably a good thing. If it's a path that's that's being led by your passions, and it's a path that is of value not only to your career, but more importantly, of added value to your community. And define community very broadly, however small or large that might be. Particularly in sort of what we do in the field of public health. And to be curious, and to talk to as many people as you can. So the only way that I was able to find these opportunities and translate my passions into these different opportunities was because I was open to talking to lots of folks who all have their own biases. And the only way to average out those biases to get to the truth and to get to what is of value to you is kind of, to use epidemiologic principles, increase the sample size. And speak to as many folks as you can. I think that has been of real benefit to me, and I think it would be to anybody who's trying to weigh their options in life.
Great, thank you. Thank you so much for that. I have read a couple of books recently by Bill George, who writes a lot about authentic leadership. And he calls that intersection between what you're passionate about and what you're best at doing the sweet spot of leadership. And I think you described it perfectly. Let's talk about vaccine development, vaccine programs. As I mentioned in your introduction, you've worked on Zika, you've worked on Ebola, you've worked on MERS. How has the development of vaccines and the development of vaccine programs evolved during your career?
What I've noticed, and I think a lot of people have noticed, especially in the past couple of years, but it was already happening before the COVID-19 pandemic emerged, is things are getting a lot faster. So the typical timeline that people would cite would be at least 7 years from conception and early discovery of a vaccine all the way through all the preclinical and clinical trials to licensure or some form of authorization. And what we saw with COVID-19 was compressing that timeline down to less than a year. Now that is a little bit misleading because a lot of the work that went into the design and the early discovery and development of the vaccines, that's based on at least a decade worth of research and investments, which, and I can say that with confidence because I was involved in the development of those kind of foundational science for those vaccines. But nonetheless, the timeline in terms of the development, when people say, okay, now we're going to really make a vaccine for this, and to getting into to people's arms and out into the global marketplace, that has compressed significantly. The science is a lot more sophisticated. So we've moved in terms of gene-based vaccines from DNA, which for 30 years we were trying to get to work and they just really wouldn't work in humans that well, to mRNA, and which had a lot of issues in terms of stability, and we were able to crack that nut. Structure-based design of vaccines, that has been incredibly important to developing antigens, immunogens that elicit a stronger, more potent immune response for a variety of pathogens, including SARS-CoV-2. And that involves the resolution of the structure, the whole topography of proteins on the surfaces of virus down to the atomic scale. And that allows you to engineer them in such a way that you get these broader responses. That's something that has matured quite a bit over the last decade. And then I think the other part of this is on the macroscopic level, public-private partnerships. So vaccine development, for the most part, has been there used to be a lot more. Paul Offit, the inventor of the rotavirus vaccine and kind of a very important figure in vaccinology, who is based at the Children's Hospital of Philadelphia. He talks about how there used to be a lot more vaccine developers, major vaccine developers 30, 40 years ago. And the issues that we're dealing with, vaccine hesitancy now, that we've been dealing with that for a long time. And so there was a lot of players sort of got out of the vaccine development business. And then it came down to really sort of 5 major pharmaceutical companies. That is starting to reverse. There's a lot more small biotech, mid-sized companies, and then of course a large pharma, but then also governments becoming involved. And our own government having been significantly involved in the development of the COVID-19 vaccines. Whereas in other countries, they have nationalized vaccine systems where they already do that, countries like Brazil and India. What it showed is that you need all of those partners. You can't just be the private sector, it can't just be the public sector. And there needs to be this cross-coordination, this cross-fertilization from these different sectors of society to be able to go at this, quote unquote, warp speed. And now the next test is going to be, can we develop these vaccines in advance of these epidemics, outbreaks, and pandemics? That's sort of the basis of the idea for our vaccine approach. And so what will that look like in terms of investments from governments, the private sector, non-governmental organizations, international bodies? Can we build on the successes and apply the lessons learned from Operation Warp Speed and COVAX and other collaborative efforts towards this next phase of vaccine development?
Now, that's a fantastic summary of how COVID-19 vaccines emerged. And I so appreciate your emphasizing that despite the name Operation Warp Speed and despite what on the surface looks like that it took a year to produce a vaccine, actually has a much longer lineage than that, 10 years plus, as you described. And that remains a communications challenge for us with many people, with many communities who are fearful of the vaccine because of what they see in that timeline, which is only a year.
Right.
And therefore question its value, its safety. You also mentioned that as I have experienced in my career, that vaccine hesitancy is not new in terms of COVID-19, but there are I would say some new attitudes, new behaviors about COVID vaccine that perhaps were not so prevalent earlier. Can you speak to any of that? What in your experience as a developer of one of these COVID vaccines is new in what you're hearing and seeing out in the public regarding COVID vaccine?
Yeah, so it's been very challenging. The science has been advancing. The partnerships have been advancing, but the messaging, as you said, has suffered. There's a phrase, there's a kind of a dictum that we use within vaccinology, that the only vaccines that matter are the ones that are in people's arms. You could have the best vaccine in the world and the best immunogenicity, safety, stability profiles, means nothing if it just sits on a shelf. I'm not a social scientist. I'm not a behavioral scientist. I'm not a cultural anthropologist, but we need those folks in as allies, as our partners from the very beginning of vaccine development, and need to be thinking of community engagement and community participation and communication. We do this, we're doing this better in the context of clinical trials, and a lot of the lessons that were learned for HIV vaccine trials and good participatory practices that were developed around that community engagement and the setup of community advisory boards, which for a long time, even though we learned those lessons with HIV, they stayed within the domain of HIV and they weren't applied more broadly to the development of vaccines and therapeutics for other diseases. That has changed because I think a lot of the folks who were pioneers in the field of HIV actually then came over and because everything else stopped, so they had to work on COVID-19 in some way. That hasn't carried over to after the clinical trials are done and after licensure and authorization. And when we get to implementation, we have to get better at our behavioral science and incorporate that into our vaccine development plans, incorporate that as part of, we think of a product development pipeline and we don't think about that part of it. We should not think of the end of that pipeline being licensure. The end of the pipeline needs to be vaccines getting into people's arms, or on their skins, or are in their mouths, if we have different formulations, but that needs to be the end state. And it's true, things are a little bit different now, but it's not so much the message, but how the message is being delivered. We live in such a hyper-connected world, and social media has benefits and drawbacks, of course, but it allows the amplification of a message so much more quickly and on such a larger scale than we've seen ever in the past. And that's double-edged. We can use that for the delivery of reliable information or the delivery of misinformation. And then being a vaccine developer and being part of Operation Warp Speed, which is now called the Countermeasures Acceleration Group, being part of the WHO's advisory board for COVID-19 vaccines. Being a public servant, my email is public. So you can imagine some of the emails that I get. So it's been challenging, but it's also been in some ways illuminating to see what some of the thought processes and the misinformation that is spreading out there. But we really have to, and it was sort of hard to do that in a fast-paced epidemic setting where there's a lot of chaos. But that's the other part of this. So when I talk about developing platforms for anticipation and preparation for the next pandemic or epidemics, we should develop social platforms as well in anticipation of those things and do that work now.
Yeah, I couldn't agree with you more on that. It sort of reminds me about the whole issue of program evaluation, the question that we often ask students, when should you think about program evaluation? Well, the answer is not at the end of the program, at the very beginning of the program,
Right.
Even before the program is developed. And so your remarks about when do you plan for addressing or anticipating vaccine hesitancy, it's in the development of the vaccine at that time. I think what we often don't consider when we think about social media are the social media platforms that are opportunities to convey accurate, correct information. So, we have a Facebook site for the School of Public Health. We have a Twitter account, as does CDC, and I'm sure your institution has social media sites as well. How do we use the positive, the good, truth-promoting sites, if you will, to anticipate and combat the misinformation that's out there. Dr. McCormick had a question about vaccine hesitancy, and I think we've addressed your question in sort of a roundabout way, Dr. McCormick. But if not, I welcome you to sort of restate it or re-ask it. Okay, very good. I'm really curious about your comments about anticipating the next vaccine and sort of building the platforms now for that next pandemic. How do you decide what to focus on? Which bug is it going to be?
Right. Yeah. This is something that started really in earnest after the Ebola epidemic in West Africa between 2014 and 2016. And some of the work that I was doing at the WHO as the epidemic started to wane was working on this thing called the RDR Blueprint. And the World Health Assembly tasked the World Health Organization with evaluating its response to the Ebola epidemic and coming up with a way to do better next time. And one of the things that came out of it was this pandemic pathogens of potential priority list. But there have always been these priority lists, for some time within the federal government, within the WHO, institutes and consulting companies have come up with these, and everybody can argue that they use, a better methodology than the others. What we're trying to do is get away from that list of pathogens and get away from the one bug, one drug approach, and start addressing classes of pathogens, families of pathogens. We know that in terms of emerging infectious diseases and these outbreak pathogens, 80% of them are viruses of zoonotic origin. So they come from some animal population, non-human animal population. Um, and and um, and so if we think of those kinds of pathogens, it comes down to about 24 families. So that's still a lot, but that's not hundreds or thousands of different viruses that we have to focus on at the same time. There's a slide that I show often in presentations. It's a very nice visual from a modeling group at the University of Edinburgh about 10 years ago, where they show the discovery of viruses, around 1920, right around the time of the Spanish flu, or in 1918 pandemic. That's when viruses were discovered as their own biologic entity. And over the next 100 years, the number of viruses that have been discovered that are of relevance to human populations has gone up exponentially. But the families, the phylogenetic families in which they fall into, has been plateauing into this 24 or so. And so I was influenced by that experience at WHO, and really influenced by my time at the NIH in the Vaccine Research Center under the mentorship of Barney Graham. And it was Barney really was a proponent of this. And Barney was actually the one who got me started on working on coronaviruses 10 years ago, because in 2012, when MERS emerged, and then we had SARS 10 years before that. In the interim, we had 2 other coronaviruses that caused milder common cold disease. Well, now you had 4 coronaviruses discovered within the span of a decade. This might be something that may pop up again in the future, and this might be something important to work on. And so it's recognizing those patterns, that it might be a different virus, but it's just a cousin of something we've seen before. So then how do you address the whole family? Some people think that we don't have the tools and the technology to develop those kind of broadly protective vaccines that address whole families of pathogens. And they're right to some extent. But what I also say is that what we're trying to do here is a moonshot. And when you think of the landing of a man on the moon, when JFK made that speech, 6, 7 years before, 8 years before we landed somebody on the moon, a lot of the technologies that we needed, most of the technologies that we needed to get there hadn't even been invented yet. You have to set the mission first. You have to set the goal first from the outset, and then you bring in the smartest people and the commitment of people to invest in that vision to be able to get there. I think, as I said, the science has advanced so much in vaccinology that the science is only going to advance at an even more rapid pace than it has over the last 10 years. So I don't think it's at all outside the realm of possibility that we're already getting to points where we're getting greater and greater breadth of vaccines. We have plenty of examples of multivalent vaccines from before, so it's not an entirely new concept, but we're sort of setting the goalpost a little bit higher now. And I think that's important to do, because if we are in a foot race with the next virus, where no matter how fast we go, and it's not going to be able to compress that timeline much more than a year, there's still going to be hundreds of thousands of people who will perish from that new virus, millions more infected, affected, and who's to say that the mortality rate of the next one is not higher? We were lucky in certain ways. MERS has a mortality rate of 35%. But if you had something that was as transmissible as SARS-CoV-2, but as fatal as MERS-CoV. So in those situations, a year matters a lot. So why not set the mission now for developing these vaccines that can protect against things that we haven't even seen yet?
What this brings to mind also, Dr. Modjarrad, is the current conversations about the flu vaccine, the development of a kind of flu vaccine that's sort of universally applicable in all flu outbreak settings.
Yeah, that's a large part of what our work started from. Myself and my co-inventor of vaccine, Dr. Gordon Joyce, we both came from the Vaccine Research Center. We both worked on the Universal Flu Program there, and used the same platform that we were developing for universal flu vaccine that we've now adapted over to coronaviruses.
Well, I know that we certainly have quite a few students who are in the audience and who are often find it challenging to balance being a student and working. The proverbial life-work balance. Over the course of your career, in addition to professional appointments, you served as a lecturer, presenter, on editorial boards, numerous committees, as we mentioned in your introduction. All this while you're doing cutting-edge research and publishing articles in leading journals. How do you balance all of this? How do you balance your workload and prioritize these various obligations?
Well, that is, I think, maybe the most important question. And I don't know that I have always balanced all those different aspects of my life successfully all the time. I've tried, but it's been a journey of learning how to do that. It's not one of these life skills that you're taught in school.
Yeah.
One of the ones that you have to pick up, and maybe it should be. And what I can say is that I'm gonna show you how much of a super nerd I was and still am. I juggle. I do a lot of juggling. Actual balls and pins and all that kind of stuff. I was the president of the juggling society at Duke. And when I learned how to juggle, I actually taught myself how to juggle one summer in middle school. And then people taught me sort of how to do it better. And they said, one of the ways, to get better at it is don't focus on one particular ball. You sort of have to keep your focus sort of a little bit in the distance and then have everything in peripheral vision. And so that's sort of kind of a lesson that I've tried to apply to juggling different parts of my work. But the other thing that I'll say is that one of the things that I think I didn't really understand is that work is one facet of life. It is not life. And some of the other parts of my life have suffered. And I have had to course correct that to some extent and take stock of what is really meaning and value. My family value matters a lot to me. And I think that's what you have to do. You have to sit down and say, what matters the most in life? What, at the end of it all, when you look back, what do you want to say that you accomplished? What will you feel good about? And work is part of that, but not all of it. And there's no one formula. It differs for everybody. And so I wouldn't presume to say I have the answer, because I haven't always had the answer, and I've had to learn it just like everybody else.
And I think it's so important for students to hear that very thing, that that none of us has the complete answer for that, and it's a constant struggle for all of us who are involved and engaged. It's this constant rebalancing, this constant shifting, the juggling analogy you used, which is wonderful. Well, we have just a few minutes left. We have another question from our audience. We have about 4 minutes. As the principal inventor and lead for the U.S. Army's vaccine against COVID-19, how has your and your team's work been impacted with each new variant of the virus? Can you at least touch on that?
Yeah. So we were, from the very beginning, January 10th, 2020, when we sat down and laid out what kind of approach we wanted to take. We had already been working on MERS. We had the only research and development program in the Department of Defense on coronaviruses at the time. And we were already working with this ferritin nanoparticle platform, not as a way to address MERS-CoV, but coronaviruses in general. So we knew that viruses mutate, particularly RNA viruses. We knew that there would be different strains or variants of the virus. And then we knew that there would be new species in the future that would likely emerge, just as they had over the past 2 decades. We have not been, our platform has not been affected all that much, at least in terms of the design and the approach we're taking, because we've always been focused on the broader long-term approach that is inclusive of different variations of the virus. And it sort of is in some ways a good stress test for us as we tested against all these different variants to see how successful we've been so far in addressing the diversity of viruses that are emerging.
Wonderful. We have just a little over a minute left. Dr. Modjarrad, is there any closing comment that you would like to provide to our students in particular?
Well, I want to first thank you again for inviting me and having the interest to talk with me. And I just want to say that whatever successes that I've had have come as a result of the education that I received and the mentorship that I received over the course of that education. And those were very formative years for me at UAB, at the School of Public Health and School of Medicine. And I think it's been an outstanding education that has really set me on the path that we talked about today. Thank you.
Great. Well, thank you so much for taking the time to join us for this. And we look forward to the time when you can travel and actually come back to the school.
I look forward to it as well.
Okay. Thank you so much.
Bye-bye.
Thanks to our audience.
Thank you.
Good day.